hand the session over to Pascal. Thank you.
Hi, everyone. Thank you, Lisa, for the introduction. Thank you to Lisa, Stephanie, and Esther for all the support that you've provided to me. I'd like to start by thanking the BC Center for Palliative Care for giving me this unique opportunity to share this program that is so close to my heart. And thank you to all of you as the participants who are giving some time and attention this afternoon. I hope after we're done, you'll feel that it was a good use of your time. So with any other program, as a community-based program, it's always kind of interesting to figure out how did this program get started? What was the original need? In our case, it turned out about 10 years ago, I'm part of a faith-based community here in the Lower Mainland. It's the Ismaili Muslim community. About 10 years ago, we had about a 75-year-old female from our community who had a really horrendous end-of-life care experience. And the family approached some of the leaders of our community and advocated for there to be some support. They really wanted to make sure that other families that were going through something similar would not feel so lonely, disoriented, and would have a bit more support in place. So the leaders, because I happened to be working on the palliative care unit, they approached me and said, can you come up with something that we can work with here? And so we took a year where I worked with volunteers from a cross-section of our own community to conceptualize the program, to kind of figure out the mechanics of it. And then we took about 6 months to actually pilot the program to make sure we kind of worked out all the kinks out of it. And so we went live in September 2017. So believe it or not, we just literally marked our 8th year of operation. The program continues to grow, continues to stay exceptionally busy. So it's my pleasure to share with you this afternoon some of the mechanics of our program. So what I'd like to do is talk a little bit with you about sort of the nuts and bolts of our program. We do collect a lot of data, anonymized data, so we can have some idea of what we're dealing with. So I would like to share with you some of the data that we've collected. What are some of the takeaways and lessons that we're kind of walking away with? What are the next steps for our own program at this point in time? And then leave it open for a Q&A session after that. I find when I do these sessions, there's never enough time to answer all the questions. I'm hoping if we can get done in about 35 minutes, there will be time. But I will also at the end give you a slide with my personal information. And if you want to carry on your conversation with me privately, I am more than happy to do so. So with that as a bit of a start, I'd like to talk to you first of all about the principles of our program. We spent a lot of time thinking about these principles because we knew that as the program evolved, there were certain things about the program, the essence of the program, that we did not ever want to lose. The first of our principles was to avoid duplication. In working with the palliative care sort of ecosystem here in the Lower Mainland, I am convinced beyond a doubt that we actually have a very robust palliative ecosystem already in place at this point in time. We have some remarkable care providers, remarkable in terms of not only their compassion, but their ability as well. And also the palliative program does offer certain resources for patients who qualify. So what we're finding is that it's not so much that we have to create these resources or create this kind of ecosystem. It's already there. One of the challenges we're finding is that it's the navigational aspect that continues to be an ongoing sort of challenge for patients and families and healthcare providers as well. What do I mean by that? Well, for patients and families, we consistently find out that they just don't know. Sometimes they get lucky and they have folks that know a lot about palliative care. More often than not, they actually have no idea who to talk to, where to turn. So it's a bit of a challenge for them. The second part of it is that we know in terms of even healthcare providers, folks that are familiar with the palliative ecosystem tend to know exactly how to access it and what are some of the perks that come along with it. But folks that are not aware about it don't know. And so what you end up doing is that even if these healthcare providers are trying to help patients and families, those referrals tend not to come to us in a timely way. So you've got that as a second dampening factor. And the third is where you actually have, there's a bit of gatekeeping that goes on with good intention, but not with very good consequences, because there's a tendency sometimes to say, no, you don't, I don't think you qualify for this. Or if there is situations that don't fall into a neat box, the easier thing to do is to say, no, you don't qualify for this at this point in time. So really, if you're able to kind of have a good navigational system in place, you're actually able to kind of helpfully surmount some of those challenges. The second thing that we wanted to make sure was that we had a focus on a self-advocacy. Our program is run completely by volunteers. So we don't have the resources to accompany patients and families to every session that they go to or every specialist that they meet. And nor is that our intent. At the end of the day, we find from a selfish point of view, if we can actually spend most of our time educating and helping people problem solve, and help them advocate for themselves when they go talk to their patients, to their specialists and their healthcare providers, it serves a purpose because it means that we can focus on just more patients and families. And the second part of it is that what we're also finding, and that's already showing in the amount of time we've been running, is that when you have second or third family members that, extended family members that need this kind of support, or if there are friends that they need this kind of support, once a family has gone through this once, they tend to have a really good idea about how to go about doing it themselves the next time around. So in the best of all worlds, our programs become redundant at some point in time, and that actually would be a positive outcome for us. And the third, which I think is a piece that I kind of put down because I felt strongly about it at the beginning, and in retrospect, I think it's probably one of the best things we ever did, and which is the idea of no judgment, meaning that when folks approach us, our job is to listen, to provide the best kind of support that we can at that point in time. There is absolutely no compulsion on the part of the patient and family to do or follow what we ask them or suggest to them. Uh, they may decide to go to some other country and go for some of the most aggressive treatment. And then what can happen is if they come back and if they call us and say, that didn't work, expecting for us to kind of say, well, we told you so. Well, we don't ever do that. We don't ever say we told you so. And the reason why I think it was a really good move is because it kind of helped patients and families realize that this was a completely non-judgmental kind of support that we were providing, that they could reach out to us at any point in time and we would never ever come back and say, well, why didn't you do this or why didn't you do this? And we find that the trust component with patients and families has gone up dramatically, and that has kind of affected the reputation of the program within the community as well. So the next two slides, I'm going to spend a little bit of time with because these are sort of what I call the core sort of components of our program. And I, you know, and I'm trying to going to get you to wear a volunteer, sort of a volunteer's hat. But what I want to do is first of all talk about this palliative pathway, which all of you are familiar with intuitively or even sort of professionally as well. So if you go from your left of the screen to your right, we know that generally the pathway kind of breaks down into four phases. There is this immediate piece where there's a diagnosis that's happened. There is obviously a certain set of experiences around that. Then we know that there's a pathway where you see individuals kind of decline in health. And then you kind of get to that real end of life phase where perhaps you have several weeks or shorter. And then, of course, you have the death and whatever comes up afterwards as well. And one of the things you do find is that as you go from your left to your right, there is definitely an evolving of the medical needs that you have, the nursing needs that you have, the equipment and other needs that you have, the physical support needs that you have, and even the instrumental tasks that you have to kind of go through as well. So, for example, at the beginning, when you're at the immediate kind of piece, there is more of a sense about, well, do we get a second opinion? Who do we talk to here at this point in time? What kind of things should we be thinking about for our wills and so on and so on? Whereas when you get to the third part, or what I call the end of life, there it might be, well, where do I want to be when the time comes? Do I want to be at home? Do I want to be in a hospice setting? What kind of equipment will I need? What kind of support will I need at home as well? So if you're looking at it for a volunteer in our program, when we get that first phone call, we get referrals of individuals that are at all different kind of stages. And so we need to kind of figure out where that person is in the stage, so we have a bit of an idea in terms of not only what they might have experienced so far, but again, where they might be right now, what questions they might have, and what questions they might not have even thought about at this point in time. So this combined with the second slide here, which I apologize for, it's a bit of an algorithm that we kind of use to try and figure out when the patient first enters the system, sort of in here. We're trying to figure out where are they at in the overall sort of healthcare system. Are they sort of at the beginning part of it? Are they in the middle part of it? Or are they at the point where a decision has been made that the focus is going to be on quality of life, that the prognosis is less than 6 months? Therefore, there's a whole bunch of other resources that we can start thinking about offering to patients and families. And you will notice that we have got I've got these six checklists that show up on this algorithm as well. And the idea is, and I'll show you what these are like ruthlessly practical checklists that patients and families, as they're going through the system, if they're trying to figure out what do I need to do, am I forgetting something here at this point in time? There's a quick way to make sure that they have some peace of mind around the fact that all the things that they need to be doing at that point in time have been done. One of the things we also try and recognize as a program is that for patients who are not palliative, because some folks reach out because they hear about some of the resources, the kind of care that our patients and families are receiving. So they're really hoping that they can also have access to that. But it may well be that they're not quite palliative yet, or they might not quite be in that 6-month time frame. And so for those individuals, we also have a checklist in terms of where else in the system they might be able to get some help and support from as well. So combined, this slide and the one before that, what it does is it sort of gives you what I call a GPS of that patient at that point in time. So a volunteer within about 5 minutes will have a really good sense about where that patient and family are in their process at that point in time. A few questions would help us really kind of confirm, yes, this is exactly where you are. But if you can imagine, if we didn't have this, we would spend 2 hours talking to patients and families trying to get a bit of an idea about this. And as you know, when patients and families are calling you, they're quite stressed enough as it is. They've repeated their stories enough times as well. The last thing they do want to do is talk with you for 2 hours to figure out whether you're going to be able to help them or not. So what we've done is, as a result of all of these, we've also now created our own sort of orientation manual for our volunteers. And there are several things. We know that this, short-term, long-term strategies are part of any program. What we have are two distinct components of our program. One is where the volunteers are educated on sort of what the palliative ecosystem is in the Lower Mainland. And what do I mean by ecosystem? What I mean by that is all the potential points of contact where individuals are going to come across healthcare providers with some palliative care expertise. So whether it's a family doctor that has who may know more about that, you have oncologists, you've got the palliative care units at the hospitals, you've got the palliative care teams in the community, you've got the pain and symptom management sort of options at a lot of the cancer clinics as well. So we kind of make sure that our volunteers have a really, really good sense about what all of those areas are. We also cover a lot of other things in that orientation, such as DNRs, advanced care planning, ethics and confidentiality. So we just want to make sure that our volunteers have a really good sense about all of those things. But we also focus on the skills for the volunteers as well. So typically, our orientation is about 20 to 25 hours over several sessions, where we really want to kind of make sure that when the volunteers are reaching out to that first patient and family, that we really zeroed in on things such as listening skills, the ability to ask right questions, the ability to maintain boundaries, the ability to maintain confidentiality, and so on as well. And the idea behind that is that we know, and and especially if our volunteers also have the capacity to speak multiple languages. You'll see later on from our data, we actually have a lot of older patients as well. So trust building in terms of just not only the knowledge, but also the language aspect of it, we find everything is super expedited. You just within about half an hour, if you do it the right way, the patients and families kind of really take a deep breath and say, I think we're now finally speaking to somebody that might be able to help us as well, which is kind of super important for us as we kind of go along as well. So then the next part is in terms of to give you a bit of a breakdown of, well, what exactly does our work look like? So there are several things, as I mentioned, that the volunteers are kind of equipped for. First of all is just the navigating. For an outsider, this palliative ecosystem can seem extremely opaque if they don't know what the different functionalities are. So we spend a lot of time making sure that folks know what this ecosystem is, where to turn to, who to talk to, how to talk to them, all of those kinds of things. We also, as you say, as I mentioned, we focus a lot on the listening. Listening partly to kind of really get a good sense of what the need is rather than us projecting our need. But the second part of is also that we find a lot of patients and families, at least in our faith-based community, they tend to think of this journey as a very private journey. And so it's not like they go and talk to a lot of people about this. So when we kind of are able to provide some good, deep listening, it's actually very therapeutic for the patients and families as well, that they're able to kind of really share with us what some of their issues and concerns are, including if there are some family dynamics that we should be aware about as well. The third part is, of course, the coaching, which is, okay, so now we've given you all this information. How are you going to go about doing it? So, for example, if you decide that you want to meet with your family doctor and have a discussion about this, should you book a meeting in the morning? Should you book it at the end of the day? Should you try and let them know ahead of time what you want to talk about? Should you go in with some of the paperwork with you, because a lot of physicians' offices don't have DNR copies and so on, so they have to download all of that information. So if you have everything ready, within about a 20 minutes, you can have a 20-minute sort of session. You can actually have a very productive outcome at the end of it as well. We also do a lot of educating. The amount of terminology that we use in healthcare and in palliative care is mind-blowing. So a lot of patients don't know, well, what does a DNR mean? What does, a home death notification mean? What's a palliative care unit? How is a hospice different from this? Yeah. So there's a lot of educating that we're doing along the way, so that again, they just get a really good sense about practically what does it mean for them when they're trying to reach out for some help and support. We also spend a lot of time on resources. We know that for individuals with a potential prognosis of less than 6 months, that there is the BC palliative care benefits that may be available. But folks also have other resource needs as well. They might need some help trying to figure out who do we talk to about wills and so on. Or some of them may say we want to augment the care that we're getting from the palliative program. Are there private caregivers out there that, you guys might know about? And so we try and keep as much of that information accessible, because as we work with patients and families, we try and draw from them as much knowledge as we can in terms of how they kind of put their own care in place, because there can then be this network of care providers where we have some ready-made phone numbers and so on that we can share with other individuals that are in desperate need of some of those supports as well. And then finally, every now and again, you just get really lucky because you have this planning opportunity where a patient and family approaches you early enough in their end of life sort of process that you're actually able to kind of help them manage its stage in a very anticipatory way, so that you're able to maximize the amount of control that they feel as they're going through the process itself. This as compared to the phone call, overnight, saying this person has got 24 hours and we don't know what to do here at this point in time, which is a very different kind of experience for a patient and family. So in terms of our referrals, we make sure that every referral is followed up within 24 hours. We have a best practice standard within our own team, which is less than 3 hours. Because one of the reasons we do that is when we get that referral, we don't know how urgent it is. So we need to know, so we kind of follow up, make as though everything is urgent. That referral has to become with the express consent of the patient. In other words, you can have individuals out there that might come and say, oh, this family member needs help. Can you follow up? We would never, ever do that without consent from the patient and or the family. We also, what we try and do is in terms of our referral networks, and I'll show you on one of the slides how they've kind of broadened as well. what we do is there are certain individuals in that referral network that are very sort of important to the patient and family. For example, a spiritual care advisor or other kind of support. And so what we do is where we can, when we have individuals that come to us, and when we know there's going to be some complexity, we will ask for the patient and family, is it okay with you if we share information with this referral person that has sent you to us, with the idea that those important people remain involved in the care of the patient and family as they go through their end of life process. Our follow-up, we do it in person if needed. We have elderly individuals who don't like to use technology. And so they say, well, can we at least meet for the first time and just have a face-to-face? They kind of need to know who they're talking to. So we do that. We try not to encourage it because, ideally, if we can do things virtually, it's kind of better for us, but if we need to. And as it turns out, probably about 35% of our patients are actually in person for the first session that we do. We're also available by phone, by Zoom, by email or texting, and later on I'll give you some data about how much of each of those we have done since the program was started. And then again, we are available. It's not just a one contact operation. We know that the end of life care process may require multiple contacts with us as conditions and situations evolve. And again, there's a specific data piece here which you might find interesting, which I'll share with you in a bit as well. I talked about those checklists at the beginning, and these are what I call ruthlessly practical checklists. So depending upon where you are in the system, you may have certain needs. So, for example, if you look at checklist one, I'll bring your attention to the compassionate employment insurance and the terminal illness CPP disability. A lot of patients don't know about compassionate benefits EI. How do we apply for that? What does it mean? Oh, you mean two family members can be off back to back? How does that work? But the second piece is the terminal illness CPP disability. You talk to most people that are gone on CPP disability, they'll tell you how horrendous the process has been, how long it takes, can take several months. Well, what has happened is that Canada Pension has actually worked it out so that for individuals who are palliative, the paperwork is about, I think, 2 or 3 pages long. You send it in, a response comes back within 5 days. So there's a recognition that palliative patients don't have months to wait for your decision to come through. By the same token, if you go to the checklist here, you can see that, things such as, when you're needing extra care, some people don't know that if you have life insurance policy, you can ask if some of the monies can be forwarded to you ahead of time so that you can use it for your care or for other things that you may want to as well. There's also the home death notification paperwork that if you're going to be passing away at home, it's kind of important to kind of think about that so that it becomes like an expected death at home, so that you don't when the person passes away, you don't have any worries in the back of your mind, will this end up becoming a coroner's case because a patient died at home, and will somebody come back and say, why did this happen, basically? So as you look at the checklist, you'll see a lot of similarities from each checklist to the other, but you'll also see some distinct differences depending upon where in the stage you are as well. So the data, what do we collect basically? So we really, as I said, it's all anonymized, so we don't keep any track of names and so on, but we do want to know how old the person is, male, female, where in the lower mainland it is that you're coming from, a quick medical summary, sort of what did you need, what did we do, and what was the outcome. And so this serves two purposes. One is that if there are any potential trends that are beginning to sort of appear for us, we're able to identify them early enough, and so that we can then go back to the leadership of the community and kind of start talking about this. This is showing up quite frequently. We need to start thinking about how can we anticipate and plan for it. But the second part of it is that I refer to the volunteer orientation. This becomes incredibly rich material to create your case studies and your simulations and so on as well. So when I first started this, all the case studies were from the back of my mind. Oh yeah, I've seen this in a professional setting. I know how this works. Now every case study we do is actually built on real life situations that our volunteers have come across. So what that means is the volunteers are a lot more confident in terms of, yeah, this is tried and tested. But the second is that we can also fine tune our learning and the tools that we have so that we continue to get better and better at what we do. So now we jump into the data. So we've had in total up to now, since the program started, we've had 111 families reach out to us. Actually, it's 115 as of this quarter. It may not seem like a lot, but I'll tell you when in one of the following slides why that's a large number. In terms of the referral ages, what we're seeing is that the majority of our referrals are 70 plus. We've had some younger referrals as well, but if you look at the bar chart, you can see from 90 plus to 80 to 84. That's a lot of folks that kind of squeeze into that kind of dimension. And what we do, and that's important because when I come back to the piece around, if you can be patient, I'll tell you why that's important. In terms of our referral sources, if you look from left to right, you start off with the idea that a lot of the referrals initially when we started were friends and family approaching us. It's kind of become much broader. So we have our spiritual care leaders that are now aware of the program. So they're putting referrals through. We have multiple committees in the community that look after the community's social needs, their welfare needs, their financial needs, their health needs. And so, of course, they are now much more aware about this program. So they also are now referring patients and families to us as well. So over time, it's that has become a much broader. We now even have MAID providers that are also kind of reaching out to us and saying, I've got a member here that really kind of might need some support. Can you kind of just, connect with them and see what they need here at this time? 40% of our referrals are still coming from patients, families, and friends. And so definitely there's a bit of that word of mouth is a huge piece for us. Then if you look at on this slide here, we have what we call our places of prayer. We call them Jamaat Khanas. They're located all across the lower mainland. But the key concentration is in Burnaby, Richmond, North Shore, and downtown. And so our referral sort of statistics kind of reflect the amount of community that we have living in each of these areas. Interesting, you'll notice we've also had referrals from Toronto, from Calgary, from Houston, from Nairobi, and you're thinking, what the hell? And the reason for that is that people have heard about it, and we absolutely recognize that their healthcare systems are maybe very different from ours. But what folks are trying to do is just get a bit of a sense about how to even think about what their families might be going through, what are some of the questions they should be asking, who should they be talking to. So they're still able to take some universal information that really applies to their own settings as well. So here we come. So in terms of I mentioned to you, we have a large clump of people that fall in the 80 plus range of folks that we're seeing. One of the things, the way that it's manifested is that today, 60% of our referrals are all related to chronic illnesses. 40% are cancer. So we're seeing whether it is the usual aging diseases that you have, cardiac fall complications, dementia, ALS, all of those kinds of things. And what we're finding is that, and then if you look at the second slide, we talked about 111 families sort of reaching out to us, but they've reached out to us more than 500 times because each patient, when they've kind of been connected, often depending on the complexity of the situation, some have reached out to us as many as 20 times, and some have reached out to us 4 or 5 times. Very few have reached out to us just once. And I think a big part of that is because the palliative care ecosystem, my sense is that it's kind of focused on this key milestones in terms of, oh, I have less than 6 months, I have less than 3 months, and so different resources start beginning to become available to you. With chronic illnesses, the prognosis becomes a really difficult thing to nail down. And so it may well be that the individual may have been decompensating for a long time, but it might be a slow decline. So you might see multiple hospital admissions, you might see treatment that works and then sort of starts plateauing. So it may take a while for the patient and family to get to that point about, should we now focus on quality of life rather than just sort of how long we have here at this point in time? So that in itself is a bit of a long curve. But also what can happen is that a lot of these patients, because they don't fit into neat boxes, it can take a while for the system to also acknowledge that there's a genuine need here and that people qualify. There may be some experiences, for example, in a hospice setting where a cardiac patient sort of way outlasts the 3-month prognosis. And so then the hospices get a little bit like, I'm not sure about this cardiac patients. But, in some instances, and there is a whole bunch of patients that absolutely fit that profile, but there are also individuals that have decompensated and are showing other signs of decline that make them very hospice appropriate. But if it was a patient, say, for example, with stage 4 breast cancer, there's a lot more experience, data, and so on that folks can say, yeah, this person qualifies. So you need a lot more advocacy. For these patients and families, the journey is a little bit more difficult. So they will reach out to us more times to get a sense about how they kind of navigate. In terms of how do we communicate, we talked about different ways. Uh, Texts have become now the fastest way. Once our first conversation has happened, once the trust has been built, it's remarkable how quickly, how comfortable people start reaching out to you by text and saying, I'm here, what do I do here at this point in time? Usually our phones are by our sides. We've had people call us at 1 o'clock at night, 2 o'clock at night, because they might be in an urgent situation. Not too many of those, thank God, but there are a few of those as well. We have obviously a lot of emails that go back and forth as well. A lot of phone calls as well. And as I mentioned, we have about out of the 115 odd people that we've seen, about 40 people, 39, 40, have actually started off with an in-person meeting to start with. And then we've sort of gone to the other modes of communicating. So, what are the lessons learned? The first lesson, of course, is that uh, you talk to patients and families who actually are able to engage with the palliative ecosystem and become part of the palliative care sort of model. I have yet to come across somebody who's ever come back and said to me, well, that wasn't a good experience. It's quite amazing how they see that being such a different experience for them. The second is, and why I wanted to show you how our referrals are coming from multiple places in the lower mainland, that indicator that the care has been good, it fits across the lower mainland. So no matter which palliative care team you're connecting, whether it's in the North Shore, in Vancouver, Burnaby, all the patients and families have come back and said to us, what an amazing experience. The third is that we find patient and family and the community are actually better prepared for end of life because they have a bit of a sense about what might be coming next and how to kind of engage around that. And more importantly, we're finding that patients and families are getting very confident very quickly, so that the next time they have a situation, it might be a 2-second phone call or no phone call at all, and they might tell you afterwards, oh, did you know this happened? But I knew exactly what to do. So you can see that efficacy sort of kicking in at that time. And of course, the most important piece is that you see a lot of trust in the healthcare providers. As I mentioned at the beginning, we got hundreds of amazing individuals in the palliative ecosystem. And so, when patients and families come across these individuals, just their trust in their entire care process just goes up dramatically. What are the more challenging things that we've seen? I mentioned to you the idea of the chronic illness, the non-oncology patients, and what some of the friction is around that. BC Center for Palliative Care has doing this very serious illness conversations, which has been amazing. One of the challenges, of course, is that with our current system, where physicians are retiring, patients and families don't have a physician, so they're kind of trying to fit wherever they can in the system. That opportunity to have those conversations doesn't happen as much as you would like. And also, as I mentioned, outside the palliative sort of ecosystem, a number of healthcare providers don't necessarily have an awareness of what palliative care. They're aware of palliative care, but they tend to think about it a little bit late, or they want to help, but they don't know what the components are and how they help the patients and families to kind of navigate their way through. So one of the things in terms of our next steps is, we want to make sure, like within our own faith-based community, we have individuals that help with bereavement, individuals that help with funeral planning, and so on. So one of our own goals is, of course, to make sure we're working very closely with each other so that for the patient and family, there is a very sort of consistent experience. To give you an example, during COVID, we know that in terms of funerals, there was a limit on how many people could attend a funeral at different points in time. And so for patients and families that were not aware that we knew that we were following, we would give them a heads up and say, are you aware? And so they would be like, oh, we had no idea. So then they were able to at least kind of work some things out that helped them prepare better. We also have a lot of immigrants, new members of the community coming in from all different parts of the world with their own experience with their healthcare systems as well, but their needs are just as crucial. And so we're trying to make some inroads with those individuals as they're coming in. MAID is becoming definitely something that we're keeping very busy with right now in terms of the number of people that are contacting to just get a sense of what it involves. And as you can imagine, for a faith-based community, individuals are always kind of struggling with, is this the right thing to do? What does it involve? And so on. And the stance we take is we just want you to be incredibly well informed. And then, as long as you're informed and as long as you know there's palliative care, there's MAID, so that at least you can make the most informed decision you can. And then, of course, one of the things we are finding right now is that, particularly with our elderly patients, when you kind of go back to the 115 patients, I would say probably less than 10 had any advanced care planning discussions. So we know that that's an important part. So several of us went through the BC Center for Palliative Care Advanced Care Planning workshop. What we've done is we actually developed our own workshops out of that for members of our own community. So what we've done is a kind of the focus on three different areas: chronic illness, individuals who've been diagnosed with dementia, and individuals with cancer. And what we've done is the case studies that we're using as part of the workshops are things we've pulled directly from our own palliative care experience. So we're able to change the names, change the ages, and so on, but the experiences are real, so that when we're discussing that with patients and families, more often than not, you'll see the audience and they will go, I think, yeah, I remember something like that happened to someone that I know, and they're better able to relate to it and kind of understand why it might be important for them. In my mind, advanced care planning is good, obviously, because we want to make sure that for folks that are not able to make the decision when the time comes, that there is a real understanding of what they would like. But more importantly, what I'm finding is when I talk about how that quality of life conversation, that, when does it start? The process of advanced care planning actually helps individuals to really start thinking well ahead of time in terms of, do I want to pursue aggressive treatment? Do I want to do something different? Because they're bringing that entire quality of life piece very much at the forefront for in their own thinking as well. So with that, what I think that's the end of yeah. And so here's where we are. I'm going to leave the slide on for a while. This is where you can reach out to me. What I wanted to let you know is that all these tools that we've provided, we're happy to share with anybody. One of the challenges is that when you do this kind of program, the orientation manual, if you look at it, you'll sit back and go, okay, well, it's got some headings and 6 or 7 lines about what to cover. You really do need somebody with some clinical experience to do that orientation. And so this is where I've sort of tried to spend a lot of my time. And what I'm saying to folks on the phone call today is that if you want to replicate any of this, or if you're interested in learning more about this for your own community, I am more than happy to sit down with you and walk you through. And if you decide we have 10 volunteers that want to be trained for this, I will even come and do the orientation for you as well and support you after that. One of the only concerns I have is I don't want consultants to take this information and monetize it. I really want to make sure that the information is accessible and free and available to every member of your community. So I will leave this slide on because the next slide is really more about questions. And so maybe what I'll do is I'll stop sharing and then pass it back to you, Lisa.
Thank you, Afsal. That was wonderful. I learned so much myself. So now we'll open up this time for questions. You can put them in the chat. I'll read the chat, or if you raise your hand, we can answer your questions as we go along here. Oh, Cynthia, go ahead. Please unmute yourself.
Hi there. Thank you. Whoops, sorry. I'm just going to close that. Whoops. Oh, there I am. Okay. Whoops. Okay. Sorry. It keeps doing
That's okay. I can hear you.
Okay. Thank you very much for this. It's very, very interesting, and I would love to know more. I'm from Montreal, Quebec. So very probably, we're all Canadian, but different
Yes.
health boards and all such. We also, I'm sure BC, being in BC, you know about NavCare. We have the NavCare program here, which We teach our volunteers to navigate the resources within the community. So I would love to know more about your initiative, this great program. But I work at the Teresa Deller Palliative Care Residence, so I'm in community development. That's my role. I'm just wondering, when you talked about your challenges, you mentioned how, which I hear is the same thing. You mentioned how often healthcare providers, doctors, even nurses, even in McGill and places that are very well renowned for their doctors or medical team, they are not very well informed of palliative care. So I'm just wondering, is that another step you would do going forward to somehow reach out to the younger medical field, like the people going into medicine in starting out as potential doctors and nurses? That would be where to let them know that this should be part of their curriculum as doctors, you
You
know.
know, that's such an interesting question. I think we've got one of my colleagues, Pat Porterfield, might be on the line right now as well, who's got eons of experience in this. And what absolutely, I think there's always been this discussion about how do we embed palliative care curriculum within the larger sort of medical curriculum, right? And it's
Exactly.
not just here. We've just started a project in Tanzania. And even when I did a project in Pakistan, it's around the world. You have this sense that, well, we've got this medical program. We only have so many years to train you. There's so many important areas to focus on. And yet, what you find is when we have residents and interns that come and become part of the palliative care experience, they always walk away with their eyes wide open, like, wow, I had no idea about all of this different, even how to have a conversation, how to even have a goals of care conversation as well. Not only that, but also if they've had any personal experiences, how are they kind of coloring and sort of maybe affecting the interaction that they're having. And then there's of course the age piece as well. If they're young and they're talking to an 80-year-old, how do we begin to do that? And they have someone breathing down their back and saying, you need to see 5 other patients right now as well, so how is that going to work as well, right?
Right.
So one of the things that I'm finding really helpful here in BC is that I think the BC Center for Palliative Care has just been doing some amazing work in terms of the amount of information that they are sharing with the public. What we're finding is that within our own community, a lot of what we do is the education is sort of like from the bottom up, where if patients and families are informed, then at least when they go in and connect with the healthcare providers, they're able to ask the right questions. And I've had a mix of experiences. As I mentioned to you in passing, a lot of the family doctor's offices, they don't even have some of the paperwork sometimes in terms of, oh, you need a
Right.
DNR, or I need this, or I need that, which means that their understanding of the system itself is also somewhat limited. And I have a whole bunch of care providers who are more than happy to help if they know what they need to do. They're like, okay, come on in, I'll do it. And then I had somebody just last week, a physician who said, well, that's not my job. And here you had a family, a patient that had fallen down at least a dozen times. There were a whole bunch of other indicators that would have made you feel like something is not right here. So in terms of educating the young docs and the young folks in there, I have to tell you, our program is kind of more focused on trying to make sure that the recipient is exceptionally well informed, knows how to advocate, knows how to articulate, and then really praying for forums like this where we're able to share some of those experiences with other like-minded care providers, so that at some point in time, hopefully it kind of filters into the larger sort of educational system.
Right.
Ongoing challenge, though. I don't know if I answered your question.
Absolutely. It is an ongoing challenge. Yep. Thank you very much.
You're
Appreciate
very
it.
welcome. You're very welcome, Lisa.
Okay, so I have a question from Sarb in the chat. So what she's asking is, who is supervising the volunteers for support, guidance, and consultation, and what are the risk and legal implications when we have volunteers doing this work?
I am the supervisor, the lone guy, and so good question about the risks and so on. What ways we manage that is our volunteer team is not 15 people. At any point in time, we have 2 or 3 people. I look for life experience. I look for maturity. I look for all kinds of things. And then they go through the orientation process. And I know very quickly in terms of, that's why we focus on boundaries and all the other kinds of things as well. When the referrals come in, more often than not, I will kind of triage them, because if there's a huge, for example, if it's a MAID referral and a lot of complexity, I will make sure I insert myself so that the volunteer kind of is by my side, and we're kind of doing the piece together so that they can learn as well. But the other part of it is that at the end of the day, what we share, things about the palliative ecosystem, for example, the navigational information. That is information that, frankly, is useful to anybody at any point in time. Our job is to make sure we have the latest information, because policies change, protocols change, and so on. We don't want to have patients and families get information that's already dated. But otherwise, in terms of, well, I'll go talk to my family doctor, or I can do this, those are things where I feel that you're kind of helping patients and families just to understand the system, and you're not in any way sort of introducing risk by saying they should do this medically or not do that medically. It's just trying to make sure that they know who the healthcare providers are around them that can help them in whatever way that they need at that point in time. But being a registered social worker, having been in the field for a long time, anything that, and we're very quick, if it's something that doesn't fit within the profile of our program, we will ask those individuals to go somewhere else for the assistance that they need. So.
Okay. Anybody else have any more questions they would like to ask?
Oh, I think there's one there.
Yep, there, go ahead and unmute, please.
Hi, thank you. Can you hear me okay?
Yes, we can, Amy.
Thank you. I put my question in the chat as well. It was just a last minute addition. I was interested in understanding more about your advanced care planning initiative. And I could reach out to you. We've trained here at the hospice I work at, and we've used the BCCPC's facilitator training program and the materials, and they're amazing. And I thought I heard you say you had adapted them to different
Yes.
groups, and I'd love to know how you've adapted them.
Yeah, absolutely. So what we've done is, we really like that. We really follow the same model. What we've done is we've used, how do you call it? So when you do workshops, we've created some really sort of interesting slides to convey different. So we've really broken down that information and have sort of, and absolutely, I think I'm more than happy to share with you offline. But bottom line is that at the end of the day, we have, as you go through the slides, we have sort of this multiple points. For example, what would happen if you didn't have an advanced care plan in place? What might be some of the implications from a legal and other point of view? And if you do have an advanced care directive, who is the person that you're identifying? Because we're finding there's a lot of blended families in our community. And sometimes folks kind of forget to update or talk to different people. And so we just want to make sure that they understand how important it is to have these conversations within the family, or at least with somebody that they trust. And then what we want to, or what we've also done is, I find when you do these presentations, it can sound so academic. So we've actually created sort of like case studies. So, for example, with the individual with the chronic illness, I remember distinctly this one individual that we had, and we've kind of created a case around that, so that in the workshop itself, you're actually able to kind of walk through with the participants in terms of, well, what does this involve? How would they go about doing the next step here at this point in time? Why would it be important? But because the case study kind of really relates to real life experiences that have happened within our own community, which I'm sure are the same in any community, folks are able to kind of better engage, because you can create more interaction and discussion rather than sort of just make it a didactic presentation.
Thank you so much. I really appreciated that input.
You're welcome. And you can reach out to me on the Gmail address that I've given to you. I'm happy to kind of, have further discussions and show you what we've got as well. So
Thank you.
I think we've got one question from Rose here.
Yeah, hello. Good evening, good morning. I'm Rose from Rwanda.
Hi, Rose.
And, hi. We have a system of what we call community health workers in Rwanda. But the issue is that volunteerism is another issue. Because even those people who are doing volunteerism, they have their families to feed and everything. So how long and how much would sustain someone to be a volunteer?
Yeah. Great question. And I think that's a concern for us with any volunteers. So the way that, Rose, the way we do it is that I find generally there are individuals, including healthcare providers within our community that are retired, that want to give back, that have the means, that have the time. And at this point in time in their life, it's kind of working for them that they want to be able to give whatever amount of time is needed. It may look, even the 500 contacts and so on, but not every contact is 1 hour long, right? I mean, some of them are like just 15-minute touch base and you kind of move on from there. So what I find is that if I have 2 or 3 individuals at any point in time alongside me, we're able to kind of distribute the work in a really good way. It's a phenomenal learning experience for the volunteers who always come back and say, I can apply so much of this to my own family as well. About 15% of the referrals we get right now are from families with healthcare providers as sort of part of their family. And when those folks reach out to us, often it's because it's like, I don't quite know the system, or I know the system but I just want to double check something, or I'm on the firing line here. If I get it wrong, my family's never going to forgive me. And so so that you can see that that need is there. So you've got the idea that it's a small but dedicated volunteer group. We basically obviously bring in new volunteers every now and again. So if I feel that, if volunteers say to me, I think I'm going to now check out in the next 2 months or so. The beauty of this program is that you can orient, and you always have a wait list of volunteers that want to join. The orientation 20-25 hours is absolutely nothing at all, given sort of the kind of work that they're able to do. So that's how we kind of sustain. And we also have a large, as I mentioned, there were so many other sort of committees within our community that also reach out and help patients and families in different ways. So I always have a large group of volunteers that I can reach out to that can augment some of the work that we're doing as well. So, but sustainability is a really, really, really good question. And I totally hear what you're saying.
Okay, we have a few minutes left. Anybody have any last minute questions for Afzal? Okay. If there's no further questions, did I interrupt anybody? Okay, if there's no further questions, we'll close the session. So thank you very much, Afzal, for sharing and for being part of our discussion today. This was an amazing presentation, and I myself learned quite a bit. So for everyone else, we hope you enjoyed the session, and we're going to ask you if you could kindly complete a short survey. It'll pop up when you leave this particular session. Within a week, we will send a follow-up email with the session recording and summary notes from today. And for your information, our next Echo Altogether session will be Islanders Helping Islanders, Quadra's Rural Vision for Wraparound Palliative Care. So really rural, community-based palliative care initiative. So we hope everyone can join us at that time, and that's on October the 21st. So thank you again, everyone. It was great to see everyone. Thank you for giving your time today to join us, Afzal and everyone who attended. And I wish you a great rest of the afternoon. Thank you so much.
Feel free to reach out if you need anything. Okay, you've got my information. Thank you, Lisa.
Thank you.
Bye.
Bye.
Bye.